So I'm very happy to introduce our first speaker, Sarah Hunt. She is one of our phenomenal genetic counselors here at the University of Colorado in the hereditary cancer program. And she's going to start us off by giving a general overview about cancer genetics and Lynch syndrome.
Right. Good morning, everybody. Thank you so much for having me. I hope everybody's gotten some coffee and breakfast. Wanted to start off the morning just covering a little bit of Genetics 101, words that we use every day in the hereditary cancer world, but that most people, even if you have Lynch syndrome, probably aren't using all the time. No financial disclosures. Didn't know if I was supposed to do that or not, so figured better safe than sorry. So I wanted to start out, those of you who have seen a cancer genetic counselor have probably seen this pie chart showing that although cancer is common, hereditary cancer, which is due to a single gene problem in a family, is relatively less common. It's only about 10% of cancer. And of course, Lynch syndrome is part of that hereditary cancer pie. And I also wanted to chat a little bit about the history of Lynch syndrome because I think it's important to understand where some of the data comes from, where some of our past terminology comes from. So it was early in the 1900s when people started describing this family G, which Dr. Safadi will talk more about later. And this family was actually later found to have an MSH2 mutation. And then in the 1960s, Henry Lynch, who Lynch syndrome is named after, started publishing about the familial linkage between colon and uterine and other types of cancers. And then it was in the 1990s when we started diagnosing a condition called hereditary non-polyposis cancer, or HNPCC, which we now just call Lynch syndrome. And initially, this was diagnosed based on family history. So before we had genetic testing, it was just based on what cancers are we seeing in the family. And then a few years later, in the mid 90s, is when those mismatch repair genes were discovered, and we were able to link those to Lynch syndrome. And then in the late 90s, the first guidelines came out recommending that some tumors be screened for Lynch syndrome. You'll hear more about the Genetic Information Non-Discrimination Act later, but that in 2008 helped open the door for more people to get genetic testing, as did the 2013 US Supreme Court decision that struck down a gene patent that enabled more people to have genetic testing for multiple genes at once. In 2014, we started to see universal screening for Lynch syndrome in colon cancer tumors. And then in 2022, the CU Center for Personalized Medicine, or the Biobank, started calling out patients to let them know that they had Lynch syndrome, which is how many of you in this room found out about this diagnosis. So we've come a long way, and of course, still a long way to come in what we understand about the cancer risks and how we can prevent them. But our current definition of Lynch syndrome is if you have a germline or a hereditary mutation in one of these genes, and we'll hear much more about these genes, but there are a couple of other types of Lynch syndrome that I just listed there as well. Occasionally a constitutional MLH1 promoter hypermethylation. If you've never heard about that, don't worry about it. But if you do have that, know that you are part of Lynch syndrome as well. And we know that about 1 in 279 people have Lynch syndrome, but most of them don't know that. So you in this room are a minority of the people who have Lynch syndrome who actually know that information and then can do something about it. Lynch syndrome in general accounts for about 3% of colon cancer and about 3% of uterine cancer. So overall, when we think of cancer in general, again, it's less common, but in the world of hereditary cancer, 1 in 279 is actually fairly common. When we think about other conditions, sometimes we're saying it's 1 in 10,000 people. So a lot of people do have Lynch syndrome. So I wanted to go through some definitions that you guys will probably be hearing through some of these next talks. A pathogenic or a likely pathogenic variant isn't as scary as it sounds. This just means there's a change in DNA that's causing a problem. You might also hear this referred to as a mutation. And these mismatch repair genes are MLH1, MSH2, MSH6, and PMS2. And these are our genes that help fix errors that are made when cells divide and DNA replicates. And you'll see a picture here just depicting that we have DNA in every one of our cells. And we have about 25,000 different genes, each of which do something different in the body. So the mismatch repair genes are the ones we're focused on with Lynch syndrome. And so looking in more depth at what that mismatch repair means. So whenever our cells divide, they have to copy over all 25,000 of those genes. Sometimes they make little mistakes. And so these mismatch repair genes make the proteins that fix those. And fixing those mistakes is really important because if they keep accumulating, that's when we can lead to a cancer. And so you might hear words like mismatch repair deficient or microsatellite instability. And that just tells us that in that tumor itself, that mismatch repair is not working. And so we're seeing these mutations accumulate. And typically what happens, so people with Lynch syndrome are born with a mutation on one copy of one of these genes. And typically in the course of a tumor developing, something happens in that other copy. So whereas you start out with, one copy of a gene with a mutation and one normal working copy, over time, maybe in the colon or the uterus or another organ, something happens to that other copy. So then there's none of that mismatch repair. And that's what can enable those cancer cells to start developing. You might hear about germline versus somatic. What does that mean? Germline is the type of testing that you would have had to tell us that you had Lynch syndrome. So this is a hereditary cancer test done on your blood or your saliva that's reading through those genes that you were born with, the genes that are running through the family. Whereas somatic testing is testing that's done on a cancer itself that can help give the oncologist clues to how to treat that cancer. And as I mentioned, as those mutations can accumulate, that does eventually sometimes enable a cancer to form. And we'll learn more. You can, of course, have Lynch syndrome and never develop a cancer. But when that mismatch repair is working, it just makes it a little bit easier for this process to happen. And this is showing how cancer can form in a colon, starting with normal colon tissue, which then can develop into a polyp, which then can get, more of those problems in the polyp, the dysplasia. And we know that in Lynch syndrome, this process can happen much faster than in people without Lynch syndrome because that mismatch repair isn't working. So that's why people with Lynch syndrome have to have colonoscopies so much more often than people without, is because this process of developing cancer can just occur a little bit more rapidly. Autosomal dominant inheritance is what we refer to Lynch syndrome as being. And this just means that of those 2 copies that we have of every gene, to have Lynch syndrome, you just need a mutation on 1 copy. And then when somebody has children, they pass down one of those 2 copies of each gene. And so if they pass down that copy with Lynch syndrome, then that child inherits Lynch syndrome. If they pass down that copy without Lynch syndrome, then that child doesn't inherit Lynch syndrome. And so this is where that 50-50 risk that we always talk about comes from. Of if somebody has Lynch syndrome, that means that their siblings, their children, their parents have a 50% chance of also having Lynch syndrome. Autosomal recessive inheritance, we won't be talking a ton about this today, but there is a rare situation where 2 people with the same type of Lynch syndrome have children together. And if they both pass down that Lynch syndrome gene mutation, then a child can inherit an autosomal recessive condition, which is called CMMRD. And I think 2 years ago, Dr. Schneider talked more about this. So if there are any questions, those videos I think are available online. In terms of the cancer risks associated with Lynch syndrome, this is where I think there's kind of a moving target, right? Of some of the numbers that if you just Google Lynch syndrome that you'll see, they're from data a long time ago when we just called it Lynch syndrome based on family history. We didn't know about these different genes. We didn't know about how those risks varied. And we know that there are other genetic factors that are influencing risk as well. But this is showing some of the major cancer risks of Lynch syndrome, including colon, uterine or endometrial, ovarian, bladder, and gastric, with each of those colored lines representing a different type of Lynch syndrome. And you'll hear more from different providers today about some of the specifics of those cancers and what you can do to lower that risk. Because we know that the risk that you're born with, that doesn't mean that that's going to happen. There's a lot that we can do to help modify that. And I think just we need to recognize that some families with Lynch, some of the people in here don't have these really strong classic family histories. Some of you who have found out through the biobank, maybe you don't know your family history, or maybe there's just, one environmental cancer in the family. This is a cancer family tree or pedigree that if you've been in our clinic, you've probably seen us build that out for you. And so for this family, the only cancer is somebody who had lung cancer and smoked, and we're not seeing anything else. Whereas some families do look more like that family G that was initially described over 100 years ago, where we're seeing lots of cancers across generations at younger ages and people developing multiple cancers, and Lynch syndrome can be the explanation for that. And then I know we also have some families in here who actually had testing for a different reason. Maybe there's a lot of breast cancer in the family, and so they had testing looking to see if there was a BRCA or BRCA mutation, and they found out that they had Lynch syndrome. So there's such a wide range of Lynch syndrome, and I think that's why it's so important to know about that gene and to know what those specific risks are. And we do know that overall cancer risk is influenced by a number of different things. So yes, you can have that Lynch syndrome mutation. We know you also have those 25,000 other genes, some of which are also impacting your cancer risk. And we don't have a great way of putting all of that together yet and saying, okay, these people are higher on the risk spectrum, these are lower. We know that family history influences, chance, gender, age, of course. There are things in your lifestyle and nutrition and exercise, and we'll hear more about that today as well. Medications and environment, and then the big question marks of what else influences these cancer risks. So rapid fire genetics 101. I'm going to give you a test now. I'm just kidding. Are we taking questions now or are we waiting till, okay, no questions? Oh, can I take one question? Okay. Yeah. 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 Yes, that's 60. Thank you for pointing that out. I think when I made it, it was 100. And I think my PowerPoint tried to be smart. So thank you for pointing that out. So that's lifetime cancer risk. But the top number is 60, is not 100. Percentage of risk for that cancer. And it's also a range. So this graph is not supposed to say what those exact risks are, but just to give you an idea that those risks are different depending on the different types of cancers and the different genes. Oh, yep, go ahead. Not usually. Oh yeah, sorry. So we had a question about if the Amsterdam criteria is still valid. Not usually. Occasionally we'll see a family where our gut tells us this family has Lynch syndrome, and our technology is just not finding the answer, even with the best, most up-to-date technology. And so occasionally we'll still follow those families as if they have Lynch, but most of the time we're relying more on that genetic testing. So, okay. Thank you all. And I know there'll be more time for questions a little bit later.
Thank you so much, Sarah, for that excellent introduction.